Speaker of the session, providing our keynote address, Professor Dr. Marleen Temmerman, Director of the Department of Reproductive Health and Research at the World Health Organization. Professor Temmerman was appointed to this role in the UNDP, UNFPA, WHO World Bank Special Programme of Research, Development and Research Training in Human Reproduction in the Family, Women's and Children's Health Cluster in October 2012. Professor Temmerman is a member of ESF and has also been a member of the Independent Expert Review Group, the principal review group in the UN Secretary-General's Commission on Information and Accountability for Women and Children's Health, the Senator in the Belgian Parliament, member of the Interparliamentary Union and chair of the IPU HIV/AIDS Advisory Board, and director of ICRH at Ghent University. Having authored over 400 scientific papers and 20 books in 3 languages, I believe, and with a wealth of international experience behind her, Professor Temmerman is well placed to lead the work at the department. Thank you very much.
Good afternoon to all of you. My topic will be from research findings to practice and to implementation, because what we have heard yesterday and today in many sessions, I think it's great. I learned a lot. It's kind of discovery, and then we have products. But then, how do we make sure that these products have an impact? I choose on purpose a non-biomedical topic, not a drug, but a kind of work that has been done on the area of violence against women, and how do we go from research to action to policy. My background is a clinician. I'm an obstetrician gynecologist by training with a public health background. And I'm now working, as was said, since a couple of months at the WHO, where I'm directing a program on research in reproductive health. And as most of you know, WHO is within the UN, the organization directing and coordinating authority on international health within the system. But what maybe most people don't know, or it's less well known, we are known working on norms and standards and guidelines and ethical guidelines. But we also have some strong research departments. TDR, Tropical Research Department, might be known. The Reproductive Health Research Department is also very active. So our core functions are to provide leadership, but also to shape the research agenda and to stimulate research findings into translation and dissemination. Because doing research is one thing, and for us as a researcher, getting publications, and many publications, it's one of our major objectives. But then do we also have more responsibilities? What is done with our research data? Is that us, or do we just have to make sure that we provide good quality research outcomes and up to others to implement them or to do something about it? In other words, how much is our research kind of driven by the needs of the society? We also work on ethics, evidence-based policy options. We provide technical support and help countries, mainly developing countries, but not only developing countries, to better implementation, but also to build up their research capacity. My department is one of the departments, as I said, Department of Reproductive Health and Research, where we address a lot of sensitive issues. Our department was created 40 years ago at the time that family planning was a very sensitive issue, and there needed to be a special program within the UN that is kind of co-sponsored by UNFPA, UNDP, and others, because it was, and it still is, a sensitive topic. Also, the other areas we are addressing, such as adolescent sexual and reproductive health, maternal health, neonatal health, but also violence against women, and I'll talk more about it in a minute. So we provide leadership on matters that are critical to health. One of the most critical and still now very much at stake discussions at the time now is the prevention of unsafe abortion. We know that thousands and thousands of women and young girls are dying in the world. About 70,000 young girls die every year because of the consequences of early pregnancy and unsafe abortion. And our department produced, based on evidence and on research in multi-country studies all over the world, produced last year the guidelines to safe abortion that were adopted by the General Assembly of the UN, but are still very much at a matter of debate. Now, what are these gaps in research in sexual and reproductive health? Well, we know that some of you might know the Millennium Development Goals tools that have been developed by the UN in the year 2000 to see how we can measure whether we are going to a better world. And one of these Millennium Development Goals, I mean, we have 8 of them. I think I'm not going to list them all. Progress has been made thanks to research, implementation, and so on, in a large number of these MDGs, such as more education, access to school, access to water. The MDG that goes very slowly is MDG 5, which is the reduction of maternal mortality, because every day there are still about 800 women who die because of being pregnant, because of giving life. That is a reduction with half, but the Millennium Development Goal was to have a 75% reduction by the year 2015, which will not be reached. And a lot of this is not only due to medication, to technology, to health systems, but also to rights of women to be able to go to the health sector, not to be married out when they are 12 years old, not to be denied access to family planning, and so on and so on. So the high rate of unsafe abortion, I mentioned that already, a high unmet need for family planning. Also in these years, there are still over 200 million of women who want to use contraceptives but don't have access. High rates of teenage pregnancies, sexually transmitted diseases, and there are still 500,000 new cases of cervical cancer. I was doubting before I came here why maybe I should take HPV and cervical cancer as a kind of model, because also in that area we have screening, we have testing, and better techniques. We all know about the limitations of the pap smear, but we also have HPV diagnostic tests right now with PCR. We have the vaccine, but it's not available to large parts of the world. So our research is mainly focusing around how can we do a better prevention, how can we have better detection, pap smear screening, we know it's not ideal, but even in the best conditions, if we introduce screening in countries where there is no treatment, it's even unethical to put an extra burden on the shoulders of women, telling them you have a precancerous disease, but sorry, we cannot help you. Another topic is gender inequality and human rights issues, and in particularly high rates of intimate partner violence, sexual violence, and so on, and I'm going to focus on that. But before going into, I want to say that our department is also engaged not only in research and development for new technologies in contraception, but also in maternal health. And this morning, Barend Mons said that, I forgot the words, but big discoveries, they originate out of chaos. It was in another context, but sometimes they grow out of very simple techniques. And this is a plastic bag. This is something that we are testing right now. A plastic bag that is kind of put around the head of the baby when the delivery is blocked. So the head doesn't come out. What do we do here in our parts of the world? Well, we have ventouses, a vacuum extraction, or forceps, and we pull the baby out. But if there is no electricity, for example, then you have no access to, or forceps is not very commonly used. So now there is a new technique developed where a plastic bag is kind of glided over the head of the baby, inserted with a very soft spoons, and then I can demonstrate it. You can have some information there. So the plastic bag, and you can just pull, and the baby comes out. So this technology is originating. It's actually a garagist. Yes, car. A man who was kind of in Argentina and also loving wine. And we all know that sometimes the cork disappears in the bottle. And then the question is, how do you get this out? Apparently, it happened a lot to him and his friends because they were discussing day and night about developing techniques where you could enter something to grip in that bottle and have a system to have this cork out of the bottle. And then it worked. And then they started thinking, are there other implications? His wife, being a midwife, she said, but could you not use this kind of, and that's how it all started. And now the safety studies have been done, acceptability safety studies. Now there are multi-country trials going on. This is just to say that also technology can be very simple. But our priorities in our program are the research and development on new techniques in family planning, but also with what we have already, with the family planning tools we have, how can we do better? Why do we still have 220 million women who don't have access if we have all these technologies? Maternal and perinatal health and safe abortion, adolescents is really a big, big group that needs more attention, and violence against women. So I'm not going to read too many definitions, but violence, there was a definition agreed already in 1993 and during the General Assembly, saying that any act of gender-based violence that result or is likely to result in physical, sexual, psychological harm or suffering mainly for women, not only, but mainly for women. And if you look at the list of what it means, well, we have most of the violence, and there are good studies being done, multi-country studies in most parts of the world. There was one done in 2005, and now in 2 weeks' time, a new study will come out that is looking at even more countries, not only in developing world, but also in Europe and in the States, and with more data on the prevalence of intimate partner violence, and also the prevalence of sexual violence outside the house. Childhood sexual abuse, rape, trafficking, rape, sexual abuse in conflict situations is a hidden tragedy as well. Acid throwing, female genital mutilation, it's also one of our priorities because despite what we think, the figures are going up. There are some success stories, but with an increasing number of adolescents growing up in parts of the world where this is a challenge, FGM is really a big, big problem. Killings, dowry deaths, and other and forced marriages. We see also an increase of marriages of teenagers and even before, 11, 12-year-old girls. So violence, it's more than the beating or the physical violence in a couple or for women. There is the Beijing Platform of Action. You can read it. I'm not going to read it here, but it is on the slides, and you can see it on the website. So since in Beijing, there was, some of you might know that there have, in the field of women's health, internationally, there are 2 landscape conferences. In 1994, in Cairo, in the International Conference on Population and Development, that for the first time said that women also had sexual and reproductive rights, and governments signed it. So that was a resolution that was signed by all governments. Now, next year, 20 years later, the world will now look back and say, what has gone better? What are we doing better? Where do we still need a lot of input? And that has been put into an action plan a year later than in Beijing. Well, as it was being, this is not specifically to this kind of research, but when you want to do good research, I always told my PhD students at university, the most difficult part, I think, of the research is delivering the research question. And look then at the methodology, because you can have a lot of questions, but you have to define your question very well. Then you develop your interventions, you generate evidence, adapt, implement, and it's a circle. Then you see how the implementation is really improving. In another area we had, and we published in The Lancet 2 weeks ago, a multi-country study where the reasons for maternal death, we know them. Why do women die in pregnancy? I'm not talking about abortion now, but the 3 major killers are bleeding, infections, and hypertension. 3 medical diseases or situations that are preventable, that are treatable. In our parts of the world, women don't die, or very rarely, of postpartum hemorrhage. In most parts of the world, it's really killer number 1. So then the UN Commission developed a list and agreed on a list of life-saving commodities. If we apply medication, oxytocin, very simple, for postpartum hemorrhage. If we have magnesium sulfate for hypertension in pregnancy and fits and so on, then maybe we can save women's lives. These commodities were then applied and trained and dispersed in a lot of centers. The impact on mortality, very low. We can, if we look at our indicators, do we have the commodities available? In 80% of the hospitals and the facilities, we can tick yes. But if we look at, does it save women's life? Not yet. Why not? Because it's not only making sure that the commodities are there, the drugs are there, the medication is there, but it has to be used, and it has to be used correctly. It has to be used properly. It has to be used in the right doses at the right time, the right moment. So having research done is one thing. Developing guidelines, instructions, clinical guidelines, it's number 2. Implementing it is number 3. But then we have to go back and we have to assess our implementation and see whether women or people really get better by doing this. So as I said, it was an initial study, 2005. Now there is another one with more countries, and the results will come out this week or next week on intimate partner violence and sexual violence. And we see that it is a problem worldwide. We also did research here in Europe, in several European countries. Also, before I went to Geneva, I worked as a professor in obstetrics gynecology here in Ghent University. We did research in our own population, asking women about violence in the recent partner violence in lifetime. And there also we could see that it was up to 25% of women reported long lifetime violence, and 5% of our women, mid-class women, reported sexual violence. So this is kind of between. It depends, of course, how you fill your questionnaires, how you define, and so on. But it is a problem that is in all countries. And what we would think, that pregnancy is protecting women from having partner violence, physical violence. In a lot of studies, we see that's the other way around. Or there is no difference, or there is even more violence, because probably women are more kind of concentrated on the pregnancy, take less care of, or maybe less attention to the husband. These are just, we don't know. We haven't looked into the whys, but we see that it's there. So partner violence is associated with a range of indicators. Women who experience violence, they have, in general, their health condition is less good. They have also more kind of vague signs and symptoms that are not recognized by the healthcare providers. When we did in Belgium here our study on the women, we also did later a study with gynecologists and physicians, and we were asking them whether they see in their practice women who are victims to violence. And the answer was no, that's not my population, maybe my colleagues, but that's not within my group. It is just something that is not recognized. It's very difficult for physicians to ask for that. There is, in the UK, simple assessment systems have been developed, the AAS, the Abuse Assessment Screen. But then it is difficult still to apply. It has not been validated enough. There are more signs of mental distress, more suicide, more induced abortions and miscarriages, higher degrees of pregnancy complications, such as bleeding, placental problems. So if we see that, we have to think violence, but we prefer not to think violence because it's difficult. I mean, as medical people, we rather like to do things and to give medication, but not this kind of issues. The negative consequences persist, not only in that time of violence, but women feel more insecure, inferior, so it leads to kind of long-term consequences. And in many, many countries, that's what we see, and also here with global health and migration, in many cultures, it is normal. In Russia, they often say, first he loves me, then he beats me. That's what our Russian colleagues are telling us. And if there is no violence, it's like there is not enough interest. So it's kind of mainstreamed. We just put some quotes there from women who were interviewed in different parts of the world. So it's so mainstreamed that it's difficult to, even women, they think that the husbands are justified to use some violence if, for example, the wife disobeys or if the wife refuses sex. Also here we see very variable figures that are kind of confirmed also by the larger studies we did recently. I'm going a bit quickly. And violence is, as I said, it's largely hidden. Women don't like to come out. There are a lot of, in European countries, there are campaigns being initiated now by ministries of health, ministries of social affairs to say that don't take it anymore, don't accept, you should you should react. Also in some European countries, as I said already before, it varies usually between 10 and 25%, depending on the population, depending on the definition, but it's also a problem here. Then to end, the global estimates of prevalence on female genital mutilation, as I said, it's hundreds and millions of girls who are still threatened. It has a lot of problems, not only on sexuality, but also direct and long-term causes, mortality associated with it, and also more obstetrical complications, especially in those countries where one applies the type 3 mutilation, which is kind of blocking, so that you have a delay in the second phase of labor, and you have more ruptured genital tract with obstetrical complications. So as I said already before, doing research is one thing, developing the guidelines, that's what we do at WHO, and then we try also to implement them. Because of time, I have to be a bit, to go a bit fast. In humanitarian setting, refugee camps and settings where women don't have anything to say, no rights, no sexual power, this is even worse. And we all know, I think, the story of Dr. Mukwege, who tries to do something against this sexual violence in Kivu. I've been there several times. I don't want to describe, it's too horrifying what you can see. He can even see which militias came to rape the women because they use other they use other weapons to mutilate. And the surgery that you have to apply there, it's terrible. So also there, I think this is not really in research, but we should not forget also to do studies there and to document what is going on. Then, describing is one thing. As I said, we also want to do some interventions. And we have started doing interventions in the healthcare sector. How can we, because a lot of women come to the healthcare sector, but what can we do to make sure that the healthcare workers are better trained and better perceiving? So we are developing tools for the healthcare workers, and we are trying to train them so that they are better are better aware of the problem and that they can deal with it, because it's not, as I said earlier, it's not very easy. So we are forming researchers now within the healthcare sector. We did some interventions. Time doesn't allow to go in detail. And there are some models that can be useful for and translated to other settings of the world that can teach us on how can we try to do something about it. We have models from South Africa and Mozambique where the healthcare sector really made a big difference. And as these are, again, handbooks that we are developing now to get scale up, replicate, disseminate, and build capacity. And for those who want to know more about it, please go and visit our website where you can have a look at all the tools that are available and the results that I just presented. Thank you.